Welcome back to the Deep Dive. If you're a nursing student, maybe heading into your OB or PEDS rotation, these first hours and days of life are just incredibly intense.
Oh, absolutely. It's this huge physiological shift for the baby, right? Moving from basically floating in fluid to needing to breathe, regulate temperature, everything on their own.
And for the parents, it's like hitting hyperspeed on the learning curve while recovering themselves. It's a lot.
It really is. So today, we want to give you, the learner, a solid evidence-based guide to newborn care. We're talking stabilization, assessments, and crucially, the parent teaching needed for a safe discharge.
Yeah, we're not just listing tasks. We want to dig into the why, the clinical reasoning behind it all, that foundation you need for practice beyond just, checking off boxes.
Because as the nurse, you're the guide here. You're ensuring the baby adapts, doing those checks, but also partnering with the family, getting them ready. It's about understanding and educating.
Okay, let's jump right in. The golden moments, those first priorities right after birth. What's the immediate focus?
It boils down to three things: stabilization, safety, and really importantly, promoting that family bonding, especially skin to skin.
And the very first check we do is the APGAR score.
Yep, at 1 minute and 5 minutes, it's that quick snapshot. Appearance, pulse, grimace, activity, respiration, scored 0, 1, or 2 for each.
Let's clarify those scores a bit. Say heart rate is 95 BPM.
That's a 1 for pulse, 0 is absent, 1 is under 100, and 2 is 100 or above. Same idea for breathing. A weak cry is a 1, a good strong cry is a 2.
And these scores tell us how well the baby is transitioning.
Exactly. 7 to 10 is generally good, meaning routine care. Below 7, that signals a need for potentially more help, maybe stimulation, oxygen, warmth.
What if it's still low at the 5-minute mark?
Then you keep scoring every 5 minutes, up to 20 minutes, or until it improves. A persistently low score isn't a great sign and needs clear documentation and, potentially escalating care.
Okay. Once we're past that initial APGAR, we move into ongoing checks. Vitals, color, tone. How often are we doing those?
For a stable newborn, the standard is usually every 30 minutes until they've been stable for at least 2 hours straight.
Why so frequently at first?
You're watching for subtle things, maybe some breathing issues like transient tachypnea or early signs of low blood sugar. Those often show up in the first couple of hours. Of course, if the baby's high risk, like preterm, that monitoring might be even more intense.
Makes sense. Now, infection control. There's a key point about gloves right after delivery.
Yes, absolutely non-negotiable. You must wear gloves when handling the baby immediately after birth. There's blood, amniotic fluid. It's standard precautions, protecting yourself.
But that changes after the first bath.
Right. Once the baby's bathed and the risk from maternal fluids is gone, you typically don't need gloves for routine handling like cuddling or feeding, unless, of course, you expect contact with pee or poop during a diaper change.
Good distinction. Okay. Routine prophylaxis. 3 big ones. Vitamin K eye ointment. Let's start with vitamin K. Why is this needed?
It's all about clotting. Newborns have a sterile gut, meaning no bacteria yet to make vitamin K, and vitamin K is essential for producing certain clotting factors.
So without it, there's a risk of bleeding.
A serious risk, yeah. Hemorrhagic disease of the newborn. It can cause bleeding anywhere, even in the brain, which is devastating. The vitamin K shot prevents that.
And as the nurse giving the shot, usually I am in the thigh. What do we tell parents?
You explain why it's needed to prevent potentially life-threatening bleeding. It's usually given after the first feed, but you can delay it a bit, maybe up to 6 hours, to allow for uninterrupted skin-to-skin or that first breastfeed. It's about balancing safety and family preferences.
Always that balance.
Yeah.
Okay, second prophylaxis, eye ointment, usually erythromycin.
This one's to prevent ophthalmia neonatorum, basically, a severe eye infection that can get during birth, often from gonorrhea or chlamydia if the mother has it.
And untreated, that can cause.
Blindness, serious stuff. The ointment prevents that.
How's it applied? And what's the common pushback?
You apply a thin ribbon along the lower eyelid, inside the conjunctival sac, in both eyes. The pushback sometimes is because it can temporarily blur the baby's vision or cause mild irritation.
So parents might want to wait for that initial bonding.
They might ask, yeah. But it's legally required in most places and usually needs to be done within an hour or two of birth, even after a C-section. So we explain we'll do it right after those first few bonding moments to make sure they're protected.
All right, shifting focus now to section 2. We're looking at breathing, blood sugar, and bilirubin. Big topics. Let's start with respiratory distress. What are those critical warning signs we need to spot immediately?
You're looking for specific things. Nasal flaring, trying to get more air in. Grunting when they breathe out, that's them trying to keep their airways open. And retractions, where the skin pulls in between the ribs or below the rib cage or above the collarbone when they inhale.
And seesaw respirations, that sounds serious.
It is. That's when the chest and belly move opposite ways. Chest falls as the belly rises. It means they're working incredibly hard to breathe using accessory muscles. If you see that, especially with pale or bluish skin, central cyanosis, that's an emergency.
Okay. If there are secretions, we use the bulb syringe. There's a specific rule here, a sequence.
Yes, absolutely critical. Use it only when needed and always suction the mouth before the nose. M before N.
Why is that order so important?
Because suctioning the nose first can make the baby gasp. If there's still stuff in the mouth, mucus, fluid, they could inhale it right into their lungs.
Aspiration risk.
Exactly. Suctioning the mouth first clears the path. So if they do gasp when you suction the nose, there's nothing to aspirate. And this is key parent teaching too. They need to know how to use it safely at home.
Good point. Okay, moving to hypoglycemia, low blood sugar. Why are newborns prone to this?
Their energy stores, their glycogen, are pretty limited, especially after a tough birth. And low blood sugar, if it's bad or lasts too long, can harm brain development.
So we need to identify who's at risk.
Definitely. Babies of diabetic moms, big babies, LGA, small babies, SGA, preemies, babies who are cold stressed or sick. They all need screening, even if they look fine. Symptoms can be subtle or, not there at all initially.
What level are we generally considering too low? And what might we see?
Most places use below 40 milli-GDL as the cutoff, especially early on. Symptoms can be things like jitteriness, being really sleepy or lethargic, feeding poorly, low body temp, floppy muscle tone. But again, sometimes they look okay until it's quite low.
If the screen comes back low, say 40 or less, what's the first step?
Get them feeding promptly. Breast milk is ideal, but formula works too if needed. Just get some fuel in them quickly.
Now, the big warning, avoid glucose water. Why is that such a bad idea?
Because it causes this really rapid spike in blood sugar that triggers a big insulin surge, especially in babies of diabetic moms. And what happens next? The sugar crashes, often even lower than before. It's counterproductive, even dangerous.
So the goal is stable glucose, above 40 in the first day, maybe above 50 after that.
That's the general target, yes. And you need to explain to parents why you might need repeat heel sticks. It's about preventing long-term problems by keeping that sugar stable. It's protective, not punitive.
Okay, last one in this section. Bilirubin and jaundice. Super common, but there's a pitfall.
The visual trap, definitely. Jaundice starts at the head and moves down the body. It's really easy to underestimate how yellow they are just by looking, especially with different skin tones.
So the critical action is?
Never rely only on your eyes. You have to confirm with testing either a transcutaneous bilirubin, the TCB scan on the skin, or a total serum bilirubin, the TSB blood test.
The TCB is a good screen, but if it's high.
You must confirm with a TSB blood draw before starting any treatment like phototherapy.
And the timing of normal physiologic jaundice makes discharge tricky.
It really does. It usually peaks around day 3 or 4, often after the baby's gone home, since discharge is typically day 2 or 3. That increases the risk of levels getting dangerously high without follow-up.
So what can the nurse do before discharge to help?
Promote pooping. Bilirubin leaves the body mostly through stool. So you encourage frequent, effective feeding 8 to 12 times a day for breastfed babies to get those bowels moving. And definitely tell parents not to give water. It doesn't help excrete bilirubin.
What about follow-up instructions for parents? What must they know?
They need written info on warning signs. Jaundice getting worse or spreading below the belly button, the baby being too sleepy to feed well, or not having enough wet or dirty diapers. Specifically, by day 6, they need at least 6 wet diapers and usually 3 or more stools a day. And they must have a follow-up appointment scheduled, usually within a day or 2 of discharge, especially if discharged early.
Okay, let's talk about the day-to-day routine on the postpartum unit. Section 3, ongoing care and safety.
Right. So after those first critical hours, you settle into a rhythm. Full head-to-toe assessment at least once a shift, so every 8 hours or so. And daily weights are key.
We expect some weight loss initially, right? What's
Yeah.
the normal range?
Yeah, losing up to 10% of their birth weight in the first few days is pretty standard. It's mostly fluid shifts and passing meconium.
But if it's more than 10% or they're still losing weight after day 3,
Then you need to investigate. It usually points to a feeding issue, so you do a thorough feeding assessment, maybe involve lactation, and consider if supplementation is needed.
and checking hydration skin turgor.
Always. You gently pinch a bit of skin, maybe on the abdomen, it should snap right back. If it stays tented up, even for a second, that suggests dehydration and needs attention, better feeding, maybe IV fluids if it's significant.
Let's talk bathing. Practice has really shifted here, hasn't it? Delaying the first bath is now recommended.
Yes, big shift based on evidence. The WHO recommends delaying it for at least 6 hours, ideally 24 hours.
Why the delay? What are the benefits?
Several big ones. It reduces the risk of the baby getting cold, hypothermia. It also helps prevent hypoglycemia, and it preserves the vernix.
That white, cheesy stuff. It's actually good for them.
It is. Vernix is like a natural moisturizer and has antimicrobial properties. Leaving it on protects the skin. Plus, delaying the bath often means more skin-to-skin time early on, which helps with bonding and breastfeeding success.
So before you do give that first bath, what needs to be stable?
Temperature. Their axillary temp needs to be at least 36.8 Celsius or 98.2 Fahrenheit, and stable, usually checked twice, 30 minutes apart. And research shows immersion bathing, even swaddled bathing, is better than a sponge bath for keeping them warm during the bath itself.
Good tip. Okay, hygiene cord care. What's the current approach?
Keep it clean and dry. That's the main thing. Clean it with plain water if it gets dirty with urine or stool. Otherwise, just let it air dry. And super important, fold the diaper down below the cord stump so it doesn't rub or get contaminated.
When does the clamp usually come off?
Typically around 24 hours once the end of the cord is dry and starting to get crisp.
And the warning sign for infection there.
Look for pus, redness spreading onto the skin around the base, swelling, or a bad smell. That's omphalitis and needs immediate medical attention. For diaper changes, just plain water or mild, alcohol-free wipes are best.
All right, let's tackle circumcision. It's a common procedure, but the decision is very personal.
Exactly. There are known medical benefits, lower risk of UTIs, some cancers later on, STIs, but the AAP doesn't feel they're strong enough to recommend it for every baby boy. It really comes down to family choice, culture, religion. Our role as nurses is neutral support, ensuring informed consent, and managing pain.
Pain management is crucial. What do we use?
We have to assess pain using a proper scale, like NEPS. Then, pharmacologically, there are a few options. Topical anesthetic cream, like EMA-LA, needs to be put on about an hour beforehand. More effective is usually the dorsal penile nerve block that's lidocaine injected by the provider.
And the non-pharmacologic standby.
Oral sucrose. A little bit of sugar water on a pacifier given right before and during the procedure. It works surprisingly well as a short-term pain reliever. Combining these methods is best practice.
Post-procedure care varies a bit depending on the method, right? Gomco or Mogan clamp.
Right. With those clamp methods, the big thing to watch for immediately after is bleeding. Even a little steady ooze is a concern for a newborn. You'll apply petroleum jelly and gauze to the tip to prevent the diaper sticking.
Okay, highlight this. Any bleeding bigger than a quarter.
That's considered significant hemorrhage and needs immediate intervention. Call the provider.
But there's a specific warning about petroleum jelly with one method.
Yes. With the Plastabel, you do not use petroleum jelly. It can make the plastic ring, which stays on for about a week, slip out of place. Just keep it clean and dry. Let the ring fall off on its own.
What should parents expect the site to look like?
It'll form a yellowish crust or scab within a day or so. Super important to tell parents this is normal healing, not pus or infection. Also, they need to report if the baby hasn't peed within about 6 to 8 hours after getting home, as swelling could temporarily block things.
Okay, rounding out this section. Inpatient safety, abduction and falls.
Huge priorities. For abduction prevention, it's all about strict ID procedures. Matching bands on mom and baby, sometimes electronic tags like hugs tags. You check those bands every single time the baby leaves or returns to the room. No exceptions.
And parent education is key too.
Absolutely. Teach them never to hand the baby to someone without proper, visible hospital ID. Staff impersonation does happen. Emphasize that staff will always check the bands before taking the baby anywhere.
And preventing falls. When are they most likely?
Usually during night feeds when parents are exhausted, you need to talk to them about fatigue. The rule is, if you feel drowsy or if you've taken pain meds that make you sleepy, put the baby safely back in the bassinet before you drift off. No co-sleeping in the hospital bed, no feeding in awkward positions where you might drop the baby.
All right, section 4. This is about catching things early through routine screening before they leave the hospital. Let's start with the Hep B vaccine.
Standard practice now. All stable babies who weigh at least 2 kilos, that's about 4.4 pounds, should get their first dose of the hepatitis B vaccine within 12 hours of birth. Starts building their immunity.
But there's a critical exception if the mother is Hep B positive.
Yes, this is a must-know. If mom is HBsAg positive, the baby needs both the vaccine and hepatitis B immune globulin, HBIG, within that same 12-hour window.
Why both?
The vaccine gives active, long-term immunity but takes time. The HBIG gives passive, immediate protection from the virus the baby was likely exposed to during birth. Missing that 12-hour window for both significantly increases the risk of the baby developing chronic hepatitis B.
Okay, moving to the newborn screening. Test the heel stick. What's the rule on timing?
Super important timing. It needs to be done after 24 hours of age, but before discharge.
Why wait 24 hours? Can't we just do it sooner?
You need the baby to have had some protein feeds, usually milk, for certain metabolic disorders to show up in the blood test. Testing too early, like for PKU, can give a false negative.
And if they do have to test early for some reason?
Then a repeat test is required, usually at the 1 or 2 week checkup, to make sure nothing was missed. Catching these things early, like PKU or congenital hypothyroidism, allows for interventions that prevents severe, lifelong problems like intellectual disability. It's huge.
Next up, CCHD screening. Critical congenital heart defects. This is done with pulse oximetry.
Yes, usually between 24 and 48 hours old. We're looking for serious heart defects that might depend on the ductus arteriosus staying open. Those defects might not cause obvious symptoms until that ductus starts to close, typically around this time frame.
How's the test actually done? Where do you put the pulse ox probe?
One probe goes on the right hand that measures oxygen levels before the ductus arteriosus, kind of like blood going to the brain. The other probe goes on either foot that measures oxygen after the ductus.
And what counts as a fail on this screen?
2 things. Either an oxygen saturation of 95% or less in either the hand or the foot, or a difference of 3% or more between the hand reading and the foot reading.
What happens if they fail?
That needs prompt follow-up. Usually an echocardiogram to actually look at the heart structure. It's designed to catch life-threatening problems before the baby crashes.
Lastly, hearing screening.
Also done before discharge, usually with OAE or ABR testing. Hearing loss is actually one of the more common congenital conditions.
Why is early detection so critical here?
Because the first few months are vital for language development. If hearing loss isn't picked up early, ideally by 3 months, and intervention started by 6 months, it can lead to significant speech and communication delays down the road.
Okay, we've covered a ton of clinical care. Now, the final crucial piece, getting the family ready to go home. Section 5 is all about parent teaching and empowerment.
This is where the nurse's role as educator really shines. But you can't just dump information. The strategy matters.
Also,
Break it down. Small chunks of information. Use different methods, talk, show, give written materials, and crucially have them show you back return demonstration. Get both parents involved if possible.
and modeling behavior is powerful too.
Hugely. Parents learn so much just by watching how you handle the baby confidently, how you swaddle, how you soothe, how you position for feeding. You're showing them the how-to in real time.
Let's talk safe sleep. This is absolutely critical teaching for SODIS prevention.
Yeah.
What are the non-negotiables?
Back to sleep, always. Baby sleeps on their back, supine, for every sleep, naps, and nighttime. They need a firm, flat sleep surface, like in a crib or bassinet that meets safety standards, and the crib needs to be empty.
Empty means.
No soft stuff, no pillows, no loose blankets, no bumper pads, no stuffed animals, no wedges. Just the baby in a sleep sack or appropriate clothing on a fitted sheet. Soft bedding and overheating are major risks.
Clarify room sharing versus bed sharing. This gets confused.
Right. Room sharing, having the baby's separate sleep space, crib, bassinet, in the parent's room, is recommended for at least the first 6 months, ideally a year. It actually reduces SID's risk. Bed sharing, having the baby sleep in the parent's bed, is not recommended. Too much risk of suffocation, overlaying, entrapment, especially if parents are very tired, smokers, or have used alcohol or drugs, or if the bed is soft.
Okay, but all that back sleeping can lead to flat spots on the head, plagiocephaly. What's the countermeasure?
Tummy time. Supervised tummy time when the baby is awake. Several short sessions throughout the day. It strengthens their neck and shoulder muscles and helps prevent those flat spots.
Infant feeding, the absolute cornerstone. What's the recommendation we teach?
Exclusive breastfeeding for the first 6 months is the gold standard recommendation from major health organizations. Then continue breastfeeding while introducing solid foods for a year or 2, or however long mom and baby desire. If breast milk isn't an option, then iron-fortified formula is the alternative.
How do we teach parents to know if the baby is getting enough? It's not always obvious.
You're right, you can't just rely on how long they feed or if they seem content. You need to look at the whole picture. Does the feeding look effective? Can you hear swallowing? Is the latch good? Are they having enough wet and dirty diapers?
What's the target for diapers by the end of the first week?
By about day 6, you want to see at least 6 or more truly wet diapers in 24 hours, and typically 3 or more stools. Combine that with steady weight gain after the initial loss, and the baby being alert when awake. That's how you assess adequacy.
And a quick warning about bottles if mom is breastfeeding.
Yeah, early, frequent use of bottles, especially if not paced properly, can interfere with establishing milk supply. Breastfeeding works on supply and demand. Baby nursing stimulates milk production, prolactin. A bottle doesn't send the same signal. If supplements are needed, paced bottle feeding is important.
Okay, let's hit some common concerns. Crying. How do we reassure parents they aren't spoiling the baby by responding?
You tell them flat out. Responding to your baby's cries builds trust and security. It does not spoil them. Then you teach them soothing techniques like the 5 S's. Swaddling tightly, side or stomach position, only while holding them in a wake. Shushing sounds, swinging or swaying gently, and sucking. Pacifier or clean finger.
And colic. How is that different from normal fussiness?
Colic has that classic rule of threes. Crying for more than 3 hours a day, more than 3 days a week for more than 3 weeks. It's intense, often inconsolable crying, usually peaking around 6 weeks. A lot of our job there is reassurance that it's temporary and not their fault.
Which leads directly to perhaps the most vital safety teaching, preventing abusive head trauma or shaken baby syndrome.
This is mandatory education. You have to talk about coping with frustration from crying. Normalize the feeling it is frustrating, but then give them a concrete plan. If you're overwhelmed, put the baby down safely in their crib, walk away for a few minutes, take deep breaths, call someone. Anything but shaking the baby. That brief moment of stepping away can save a life. So critical. Okay, wrapping up the official discharge criteria. What boxes must be ticked?
Stable vital signs for at least 12 hours before they leave. A normal physical exam by the provider. They absolutely have to have passed urine at least once and passed stool at least once.
And the feeding piece.
Crucial. A nurse needs to have actually observed the baby feeding successfully at least twice and documented it. We need to see that they can latch, transfer milk, and that the parent is comfortable with the feeding method. This prevents readmissions for dehydration or weight issues.
Car seat safety check, too.
Yes. They need an appropriate infant car seat installed correctly rear-facing, usually at a 45-degree angle. Harness snug, chest clip at armpit level, no bulky clothes or inserts under the baby that aren't approved with the seat.
And a special test for smaller babies.
Right. Preterm or low birth weight infants often need a car seat challenge test, or CSCT. They sit monitored in their car seat for maybe 90-120 minutes to make sure they don't have breathing problems or heart rate drops due to the position.
They're finally follow-up, especially if they leave before 48 hours. Absolutely essential. If discharged early, they must have a follow-up appointment scheduled with a healthcare provider within 48 hours of going home. That visit is key for checking weight, jaundice levels, feeding progress, catching things that might arise after they leave the hospital's direct supervision.
Wow. Okay, that was a really comprehensive deep dive from the first minute of life right through to buckling them into the car seat.
Yeah.
For you listening, the BSN students, this is really the core knowledge you need.
It really is. You're doing everything from interpreting pulse ox readings for CCHD screening to teaching basic cord care, but so much of the value is in that education piece, explaining the why behind vitamin K, reinforcing safe sleep, showing parents how to soothe their baby. You're building their confidence.
You're not just a monitor, you're an educator, a supporter, building that foundation for the family. Which brings us to our final thought, tying back to bilirubin and elimination. We know pooping helps get rid of bilirubin. And we know breastfed babies and formula-fed babies can have very different stool patterns. Especially after the first week or so, breastfed babies might go from multiple stools a day to maybe only one every few days.
Right, that pattern shift is normal for breastfed babies as their digestion matures.
So the provocative thought for you to consider is, given that difference in normal elimination patterns, how might that influence the timing or the urgency of the follow-up instructions you give specifically about jaundice monitoring, depending on whether the family is exclusively breastfeeding versus formula feeding? Something to mull over as you head into practice.